And our final presentation is going to be given by Dr. Jennifer Malin from Optum.
Thank you all for having me this afternoon. I'm a medical oncologist by background, and I spent the first half of my career, here's the microphone, doing population health research focused on measuring quality of care and clinical outcomes. But for the last decade or so, I've been working for large health plans. So I'm going to share the perspective of what things to think about as you're thinking about how you would translate this from, bench to bedside to to something that could be, broadly adopted. So when thinking about coverage and reimbursement, there are really four critical elements to think about. One is benefits. If we're talking, is the healthcare technology a covered category of benefit? So if most of you probably don't do this, but when you go through your annual process of signing up for your healthcare benefits and you get this coverage statement from your employer, it tells you what category of benefits or what things are included. So generally speaking, as we've been discussing things today, diagnostic testing would be a kind of imaging, pathology would be standard benefits categories. But if we have something that involves artificial intelligence, some sort of predictive algorithms, there's digital formularies, that may not be part of the standard benefits. So that, is just something to kind of be aware of, that you might have to come up with a new benefits category that would include this kind of integrated diagnostics. The second important factor is in the United States healthcare system, in the fee-for-service world, in order to get paid for it, it has to have a CPT code. And there's a whole process to go get a CPT code. So again, to the extent that you're doing something, some of the discussions earlier today were more about optimizing workflows, getting people to work together better, but may not necessarily involve billing differently. But to the extent you think you're creating a new service that needs to be reimbursed separately from everything else that people do today, that involves needing to go get a CPT code and to define that service clearly so that you can get paid for it. And separate from just getting the code, you have to get reimbursement for it. So just because you have a code doesn't necessarily mean every payer will put a dollar amount and pay you for that. Typically, CMS has a process of determining coverage, and most private payers will tend to follow what CMS does. But I know from kind of one of the areas that I've focused on that reimbursement for genetic testing varies dramatically across state Medicaid plans. Some plans will cover just about anything, and some plans might cover like cystic fibrosis and one other gene and not cover anything else. So, just having a CPT code does not guarantee reimbursement. And then lastly, which I think kind of fits most with what we're talking about today, would be clinical coverage. So do you have a favorable coverage determination? And I have a couple more slides, but usually this takes the form of a medical policy or coverage determination that Medicare might make. So for clinical coverage, in general, you need to think about levels of evidence. And kind of this, I think this pyramid is probably very familiar to everyone here, but especially if you're thinking about services, they're going to be, screening, for example, anything that's going to involve, prediction in, the general population is going to require a very high level of evidence to get broad adoption. Generally speaking, at this point, for things like that are population-based and screening, both Medicare coverage and private payers will look to the U.S. Preventative Services Task Force. And I think as everyone knows, they set a very, very high bar for evidentiary standards for what they will consider to get one of their A or B ratings, which is what is necessary to lead to coverage. As you look at rarer conditions where there might not be a large enough population to do a randomized trial, but even with interventions, I know this is, everything we're talking about seems like it's more registry-based. If you're really going to look at expanding it and saying, this is delivering better care, you're going to need a high level of evidence if you want to get incremental payment for providing the service. And so really the concept that goes into coverage determinations is using that evidence to determine if there's clinical utility. And I use the example here for a genetic test, but I think it's really applicable across what we've been talking about with integrated diagnostics. It's fairly straightforward if the diagnostic is targeting a therapy. The FDA label says that you should only give the drug to people with a certain HER2 positive, something like that. There's a clear connection there. But if it's diagnostic testing, there really needs to be evidence that there's going to be a change in clinical management that improves the health outcomes. And I think kind of building on what people said earlier today, I think Charles mentioned use case, Neil, and Michael in kind of some of his discussion is specifically like as we're thinking about integrated diagnostics, what outcomes are we trying to improve? Ultimately, it's probably overall survival, but are there intermediate outcomes that are important? I think time to I think with the EGFR earlier this morning, there was timeliness of getting therapy started that was leading to better outcomes. It might be that with these algorithms, patients could get fewer tests, right? So, if the time required to go get all the tests, take time off work. So if we can kind of streamline the process, that might be a desirable outcome. But, being very precise about what outcomes are we seeking to improve, not just, it's going to be very hard to demonstrate that just somehow generally things get better. That takes decades to show population level improvement in outcomes. So what populations are we targeting and which outcomes are we targeting? So moving from coverage to value, in the value-based care world, there, as opposed to fee-for-service, there can be greater flexibility sometimes in incorporating these types of novel approaches. So value is outcomes. This is Michael Porter's equation. Value is outcomes over cost. A value-based care model pays provider on indicators of value and evolves reimbursement from paying for fee-for-service to fee-for-value. So you can see this continuum with fee-for-service on the left to capitation on the right, where a healthcare system or a group of providers is just given a set amount of dollars to care for the population. Within that context, a healthcare system has a lot of latitude for deciding what's going to be the best way to structure care or deliver care. And so, in that environment, it may be more straightforward to adopt some of these new modes of integrating diagnostics. So, in summary, if we're kind of staying in our standard fee-for-service model, it's really critical to think about the four critical elements to getting coverage. So there has to be a benefits category. You need clinical coverage, which means you need a high level of evidence to demonstrate that there's clinical utility and improved outcomes for your intended use population. You need CPT codes for the service that you want to bill for, and you need reimbursement. If you can show that there's greater value in cancer care, then you may be able to speed adoption through value-based care models. And I will cede my time for the questions.